Thank you, Dr. Qasim. Thank you, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. So my talk is about the perspective of burden of coronary disease and the perspective of cardiac surgery. So let's start with what is burden of disease. And basically, it's the impact of a disease or injury on a population. And it's measured by a unit called disability adjusted life years, which just means how much healthy life has been lost through premature death or living with illness or injury. And so there are huge studies that were done. One of them is the global cardiovascular study. And basically it looked at the global burden of cardiovascular disease, including ischemic heart disease. So basically it looked at all continents, all countries, and the graph you have basically describes the burden of heart disease in the Middle East. So I marked the Gulf regions, Qatar, Kuwait, Oman, Bahrain, Saudi Arabia, United Arab Emirates. And you can see here the age standardized mortality rate per 100,000. And in the region, the mortality rate per 100,000 ranges between 100 to 200. When we look at the daily adjusted life years in terms of the cardiovascular disease, we notice that in all countries, ischemic heart disease occupies the majority of DALYs. That's what the acronym is. And in the Gulf region, the daily adjusted life years is around 4,000 per 100,000 population. In Saudi Arabia and United Arab Emirates, comes down in Oman, Bahrain, and finally in Kuwait and Qatar around 2,000. Now, we have to wonder what is the prevalence of the modifiable risk factors. I would like to thank Dr. Ahmed for presenting a lot of that data. Also, the Gulf Heart Association published a registry data called the Gulf Race 2 study, which looked at all patients presenting in the Gulf countries with ACS, acute coronary syndrome, all comers. We see in that population that 50% have central obesity, around 40% have diabetes, hypertension 47%, hyperlipidemia around a third, and 35% are current smokers. They looked at the nationals in the GCC country and the Gulf Coast study. And this is an analysis, sub-analysis that looked at young versus older patients, the cutoff being 50 years of age. But the take-home message is that we're looking at high rates of modifiable risk factors in our population. So what's happening in the cardiac surgery population? It makes sense that what's happening in the general population and in the ACS population also would happen in the cardiac surgery population. Now, this was studied in the US extensively. This is from the Veteran Affairs hospitals. They did a study looking at the trends over the period 1997 to 2011. And you'll notice that over the years, there's a slight increase in age. There's a huge increase in the BMI, a huge increase in patients with diabetes, a huge prevalence of advanced heart failure, left main disease increased. There were some positives with a decrease in an increase in independent functional status, decreased prior MI, decreased advanced angina, decreased patients with low ejection fraction, and a decrease in current smokers. Another big study published by Danny et al. Comparing 46,000, 34,000, 29,000 in 4-year brackets spanning 2004 to 2018, we see the increase in diabetes from 32 to 44%, stable hypertension rates, obesity rates increasing from 18% to 38%, peripheral vascular disease patients slightly increasing. So those were figures from the US. There is a Spanish study which looked at similar trends, and they noticed also increase in patients with hypertension, diabetes, COPD, peripheral vascular disease. Now, we don't have a lot of local cardiac surgery data, but one small study that we did in Bahrain during the COVID times, and that's why the population is not that much, looked at all comers in terms of arrhythmias. But the take-home message from this is the increase in BMI. We're talking 29 BMI average. Diabetes was 55%, hypertension 60%, dyslipidemia 86%, 21% were smokers. So the population that we're dealing with is getting more and more complex. And so that will affect our outcomes eventually. So in conclusion, the burden of coronary disease in the GCC is significant. It is imperative that our population's risk factors are modified aggressively. Cardiac surgery patient populations will evolve into higher risk profiles due to uncontrolled risk factors unless seismic changes are made. Thank you very much.